I'm Dr. Noboru Fukuda, Chief in Non-COVID Center, Ukima Central Hospital. In this YouTube, I will present a profound diagnosis and radical treatment in non-COVID center. Purpose of long COVID center. Long COVID is a disease inducing general fatigue, sympathetic pain, sleep disturbances, and autonomic nerve disorders. After a couple of months of initial infection of COVID-19, number of patients with the long COVID is over 500,000 in Japan, in which around 30% patients are bedridden. Our medical group found that patients with myalgic encephalomyelitis chronic fatigue syndrome (MECFS) as long COVID accompanied with adrenal insufficiency. 400 patients with long COVID from nationwide had been hospitalized and received adequate doses of hydrocortisone based on the endocrinological examination result, by which 85% of the patients recovered completely. To rescue the patient with long COVID, Ukima Central Hospital established the long COVID center. This slide shows two types of causes of the general fatigue in long COVID. One is a myalgic encephalomyelitis chronic fatigue syndrome (MECFS) by invasion of coronavirus in whole brain. Another one is hypothalamic adrenal insufficiency by invasion of coronavirus in hypothalamus. Here you can see the brain MRI findings in patients with MECFS. So you can find captured area of the coronavirus infection in brain. Diagnosis criteria of MECFS. First one, fatigue at rest. Second, post-exertional fatigue. Third, sleep disorder. Fourth, systematic pain of muscle and joint and severe headache. Fifth, neurological cognitive manifestations. Six, autonomic nerve manifestations. 7, neuroendocrine disorders. 8, immunomanifestations. From these 8 criteria, more than 5 positive criteria indicates diagnosis of MECFS. Mitochondrial energy deficiency of brain cells in MECFS. The chronic fatigue in MECFS is associated with the mitochondrial energy deficiency of brain cells. In normal, brain cells produce enough energy, but brain cells in long COVID produce reduced energy. That is why patients with long COVID becomes soon severe fatigue after exercise. Damage of neurotransmitter pathway of brain in long COVID. After coronavirus invasion, if serotonin pathway is damaged, patient becomes depression. If dopamine pathway is damaged, patient becomes autonomic nerve dysfunction as orthostatic hypotension. Activation of brain microglia in ME/CFS. Here is the important mechanism of long COVID as activation of brain microglia in ME/CFS. After disappear coronavirus, brain microglia cells are activated, which induce central pathogenesis of ME/CFS. This picture shows hypothalamus pituitary adrenal axis. Hypothalamus release CRH to stimulate pituitary ACTH, and then ACTH stimulates cortisol releasing from adrenal gland. ACTH and cortisol have circadian rhythm. Levels of blood ACTH and cortisol are highest at early morning and decline to midnight. This picture shows hypothalamic adrenal insufficiency in long COVID. If coronavirus infected into the hypothalamus, then hypothalamic CRH and the pituitary ACTH levels were decreased. They cannot stimulate enough cortisol generation. Patient with long COVID with low levels of cortisol feels general fatigue, body weight loss, and appetite loss. Hospitalized schedule for long COVID. To investigate profound pathogenesis of general fatigue in patients with long COVID, patients are hospitalized and examined as following schedule. Day 1, brain MRI plus VS lab analysis. Evaluation of exercise ability by rehabilitation staff. We blood sample at 12, 18, 24 for hormone circadian rhythm, and day 2 blood sampling at 6, and pituitary loading test with GRH, CRH, LHRH, TRH. Day 3 ACTH loading test to investigate adrenal function, and start medicines including hydrocortisone. Day 4, 5, 6, patient has rehabilitation. Day 7, adjust the medicines according to the obtained data. And day 8, patient will be discharged. Brain MRI findings analyzed by VS Lado in patients with long COVID. After coronavirus infection, VS Lado analysis shows the scattered atrophy of brain tissue, including hypothalamus, to induce a hypothalamic insufficiency. Endocrinological grouping for patients with long COVID, number 144. So no abnormality was 3, and pituitary adrenal insufficiency is just 1. And pituitary adrenal insufficiency was 0. Hypothalamic adrenal insufficiency alone was 16. And ME/CFS patient number was 124, around 90%. ME/CFS patient can be grouping to following. One is no endocrinal abnormality was 23. Hypothalamic adrenal insufficiency was 76. Pituitary adrenal insufficiency was just 2. And the primary adrenal sufficiency was 23. Circadian rhythms of ACTH and cortisol. ACTH at 6 were significantly lower in hypothalamic adrenal insufficiency alone and in hypothalamic adrenal insufficiency with ME/CFS. Cortisol at 6 was significantly higher in no endocrinological abnormality than that in another groups. Response by ACTH and cortisol to CRH loading. There were no differences in response by ACTH among 4 groups after CRH loading. Cortisol after CRH loading was significantly lower in primary adrenal insufficiency than no endocrinological abnormality with ME/CFS. Responses of cortisol to ACTH loading in 4 groups. Cortisol at 30 and 60 minutes was significantly lower in primary adrenal insufficiency than another 3 groups. Urinary excretion of cortisol for 24 hours in no endocrinological abnormality with ME/CFS was around 70 microgram per day. Urinary excretion of cortisol in another 3 groups were significantly lower than that in no endocrinological abnormality. Relationship ME/CFS and adrenal insufficiency in the long COVID. 60% of patients with ME/CFS are complicated with hypothalamic adrenal insufficiency. Moreover, 20% of patients with ME/CFS are complicated the primary adrenal insufficiency. Rehabilitation program for ME/CFS. One is the evaluating of exercise ability of ME/CFS patient by 6-minute walking distance. Second, preservation of energy in rehabilitation for ME/CFS. Third, graded exercise therapy depending on the individual exercise ability. So we established special combination of medicine for ME/CFS. For hypothalamic adrenal insufficiency, hydrocortisone and cyretocampo medicine. For mitochondrial energy, taurine and noekinone. This is CoQ10. And 5-amino acid hydrochloride, 5-ALA. For microglia activation in brain, minocycline and naltrexone. For insomnia and abnormal sleeping rhythm, SSRI paroxetine 10 mg, and lamelteon. And finally, we administer vitamin B12 injection methicobal 1000 microgram. In summary, causes of general fatigue in patients with long COVID were ME/CFS 77% and hypothalamic adrenal insufficiency alone 20%. ME/CFS accompanied with hypothalamic adrenal insufficiency 70% and primary adrenal insufficiency 14%. So adequate supplementation of hydrocortisone is effective to treat the general fatigue. This is different from administration of corticosteroid. Mitochondrial damage is cause of the general fatigue in ME/CFS, for which taurine, coenzyme Q10, and 5-LA are effectively improve the general fatigue. Thank you for your attention. If you wanted to be examined and treated with our medicine, please contact us as following address